you so much for inviting me to do this presentation and talk. I'm so pleased to be able to do this. And I just want to mention, check, I am sharing my slides, correct? Okay, great. So, and I apologize for what is probably the longest title for a talk. As I was putting this together, I was like, oh, should have shortened that down. But I'm so pleased to be here. I'm really pleased to talk about kind of my approach of how I've been intersecting epidemiologic approaches and implementation science to improve gaps for polycystic ovarian syndrome. My preferred name is Noi. Please do call me that. And I'm an assistant professor in the Department of Psychiatry at CU School of Medicine. So by the end of this lecture, I hope that you can identify appropriate methods, study design, mixed methods, and outcomes in implementation science, describe and integrate appropriate frameworks for studying the processes and outcomes of a health condition, and understand one approach to the use of integrating implementation science and epidemiology methods. So it's always important to kind of start with some definitions. Implementation science is a study of the processes and factors associated with successful integration of evidence-based interventions in a particular setting. So specifically, the aim is to understand various implementation strategies, such as training and educating stakeholders, developing interrelationships, or providing interactive assistance to achieve implementation and sustainability and long-term use of an evidence-based practice. So in the past, research has really focused on the what, and now we're really hoping to understand kind of the how we do the implementation piece of it. Dissemination science, on the other hand, focuses on the scientific study of targeted distribution of information and intervention materials to a specific public health or clinical practice. You know, the aim is really to successfully spread evidence-based information to benefit public health or a clinical setting. And typically this is through what I would consider the 5 Ps. So through posters, presentations, papers, policy briefs, program materials, and then the 1 T, which would be a toolkits or how to implement a program. And so one example of implementation science is to study the effective strategies to increase vaccination rates for COVID-19, for example. And so why is dissemination and implementation science important, or why is D&I science important? And some of you might be familiar with this phrase, that it takes 17 years of research to turn into practice. Well, this is a really classic figure showing why it takes 17 years and how long it takes. And if you kind of step back for it, it's actually worse because it starts when the research is funded. And that could take, you know, half a year to a year to actually get the research funded. And then there's another 5 years to actually get it going and to get it published. So you can see how long it takes from when it's reviewed, accepted, published, and finally implemented. But the more, you know, specific take-home point here is that it actually takes 17 years to turn 14% of original research to benefit patient care. So nothing really happens with that 86% of research that we produce, other than really sitting on, you know, what we would consider the proverbial bookshelf. Just kind of hangs out there and starts to collect dust. And even if a health program or an intervention is 100% effective, it typically depends on whether it will be adopted for use, if there are enough people trained to deliver the intervention, if those trained people choose to deliver the intervention, if there are enough patients or people eligible to actually receive it, and whether organizational leadership determines the program to be worth sustaining. So you can see there are many factors that could influence kind of the long-term use of a clinical practice, program, or policy initiative. So what methods do we typically use in implementation science? And so for this talk, I'm primarily focusing on implementation science. That's primarily because of my background training. I did a fellowship in implementation science specifically, but there's much more within dissemination science. And in some ways, they're really 2 separate scientific backgrounds. dissemination science as a background is also continuing to emerge and establish kind of its own stake in the game. So this is a really high level view of the characteristics of dissemination and implementation science, or D&I science. You know, these characteristics are somewhat in contrast to traditional research. And so while all of these are important, all of these characteristics are important in D&I science, there is really a greater focus on understanding kind of this multi-level complexity in care, whether interventions can actually be scalable and sustainable in the early stages of planning. Typically, we have focused on the later stages of implementing a program, but how do you think about scaling and sustaining a program from the start? How are stakeholders involved and relevant? And this is a key component and a key importance of our program, and to ensure that, if it's relevant for our key stakeholders, we want to ensure that they're also being adopted and used. And then there is an explicit respect for diverse approaches and utilizing different perspectives, goals, and methods to answer public health issues. And so while we strive to aim and achieve all of these characteristics in one study, this can be kind of a whole program of research for an implementation science type of study. And in the past, typical research, or at least with my training as a clinical health psychologist in behavior change programs, we've always focused on kind of the what. What is it that we're trying to study, which tends to be quality improvement initiatives, empirically superior treatments, and trying to understand the various health outcomes at a patient level. But then there's this big gap kind of in the middle. For the longest time, we would call it kind of like this black box. What was happening when we were actually trying to implement an evidence-based program into achieving health outcomes? And so the early stages of implementation science started to focus on the how do we do it? How do we implement it? How do we get it out to the people who can really benefit from it? As well as, what are the implementation outcomes that we need to focus on? And so the early stages of implementation science really focus on kind of this area. Now, as the science emerged, the studies are now really focusing on kind of all aspects of this relationship. So not just going back for a sec, not just kind of pieces of this, but what are we trying to implement? What are the strategies that we need to utilize to implement? And then what are the 3 different outcomes that we would want to achieve, both from implementation, service, as well as health outcomes? So this is just a brief overview of study designs that are often utilized in implementation science to work towards kind of meeting the characteristics that I described a few slides earlier. So implementation science studies in particular are designed to support this multi-level complexity. Implementation science came out of real world clinical care. Like how do we mimic and replicate what is happening in a successful clinical setting to a setting that's not as successful? And that can be really messy. Clinics are messy, real world care can be really messy. And so we need designs to support how to capture that messiness and to pull out what we think might be the most successful for us to study. We also want to ensure that the studies are also pragmatic. So there's a big push more recently on conducting pragmatic randomized clinical control trials. And the pragmatism here is really related to, Can your intervention be delivered exactly how it would be in real world care? Can it be, instead of the research team delivering your intervention, can it be delivered by someone who works in the clinic? Are all patients eligible to receive this intervention, or do we have strict inclusion and exclusion criteria as we would in a traditional randomized controlled trial? So part of that is really the question for you as a scientist as to, what kind of study would you want, and what sort of questions are you trying to answer? And then the ability to test the adaptability of the interventions, again, to ensure that we are following this and setting this from a real world perspective. In addition, stakeholder engagement and user-centered design are particularly important to ensure that the interventions are adopted at both the individual level. So meaning, you're training the person who works in that clinic to deliver the initiative, or you make it usable to the patients or to the folks who are actually going to use it at the end, or it's adopted at the setting level so that it becomes a part of kind of routine clinical care. Because I'm a clinical health psychologist and I work, specifically within a primary care setting, a lot of my examples come from the clinic setting. And so one initiative you can think about which is, like a real implementation science study, would be integrated behavioral health care. How do we integrate into behavioral health providers in various primary care and specialty clinics to ensure that, we're meeting both implementation outcomes, service outcomes, as well as patient level outcomes. Implementation science study designs are guided by theories, models, and frameworks, and frankly, a lot of them. And if you're new to the field, there's over 100. And if you're new to the field, you can feel really overwhelmed by the number of theories, models, and frameworks that you can draw from and utilize from. And one question that is often asked is, how do we choose this one versus this one? And it really, it actually comes down to whatever your favorite is. There's a lot of overlap between a lot of the models, theories, and frameworks, and it really just, I think it depends on scientist choice. So, and it's very common to use, multiple theories, models, and frameworks in one study. So for example, the health belief model, which is an individual level model, helps to understand individual user intention of intervention engagement, not just intention, but also motivation to utilize that study or that model, and what would be some reasons that someone doesn't use it. The replicating effective programs is an evaluation framework aimed to walk through the process of an implementation and ensure that you are evaluating it for ongoing implementation, as well as maintenance and evolution. So you can kind of look at the effective programs, replicating effective programs model as a way of kind of what's the pre-implementation. How do you study? What do you need to do pre-implementation? And then once the program starts to get rolled out, how do you evaluate during and then after implementation? And then it's also very common to use, this is an implementation framework, to use a common evaluation framework, which is the REACH effectiveness, adoption, implementation, maintenance framework, or the RE-AIM framework. And this is really to, again, evaluate the program, as well as evaluate kind of the implementation outcomes that I had mentioned earlier. We also used mixed methods designs. This is very common, and it helps us provide a better understanding of research issues than either research and clinic issues than either kind of analyzing quantitative or qualitative data alone. So the qualitative methods, this would be like interviews, focus groups, observations, doing ethnography work. It really allows for an in-depth exploration and understanding to the successes or failures to implement an evidence-based practice, or even identify the strategies that would lead to successful implementation. while quantitative methods, which are typically surveys, we're also looking at electronic medical record data, some implementation outcomes, the percentage of people who are actually reached. These are used to test and confirm hypotheses and gather a breadth of information of predictors that could lead to successful implementation. So this is a typical kind of mixed methods design where you can collect qualitative or quantitative data separately. Whatever your results are informs what kind of quantitative or qualitative data collect. And this is where you would then interpret the results. So you could do it sequentially in various designs to explore or one should say explain your outcomes. And then concurrent designs where you essentially collect qualitative and quantitative data concurrently to interpret your results. And whatever, there's always one that's emphasized more, whether you're collecting qualitative data to answer some of your questions and using the quantitative data to support that, or quantitative data is collected and use your qualitative data to understand maybe why this outcome may have happened in that way. So I know I breezed through and I gave a very high level overview of typical implementation science approaches. If you do have an interest in this area, love to talk to you about that more, as well as direct you to the website that we have here, which is a nice resource created by my colleagues here at the University of Colorado. We also have a dissemination and implementation science team that can also serve as a consultant for your studies if you would want to include an implementation science aim into this. So I want to also highlight kind of the synergistic relationship between epidemiology and implementation science. There are two fields, but they both are really generating important outcomes and information and data to help inform the other. So implementation science really relies on epidemiologists to produce evidence on disease risk, factors, predictors, and trends. And in turn, implementation scientists can produce effective evidence on strategies to control the disease or reduce incidence and prevalence of a disease. And so both fields are really needed for us to determine the causes, solutions, and implementation strategies to drive policy and change at a population health level. So both fields are trying to improve population health, and we kind of go about it in different ways, both different and synergistic ways. And so, and kind of utilizing and really being guided by the synergy between implementation science and epidemiology. This was the impetus for my current study, which is the endocrine and mental health study, or what we like to call as team health study. So this study aims to understand mental health experiences of people with PCOS at the population health level. And PCOS can affect up to 15 to 20% of reproductive aged females. And Dr. Mahalingaya wanted me to share kind of how I got into or interested into PCOS. And it started, I think I've been lucky that it started really early in my clinical training, where I was at a college university doing one of my clinical practicum trainings and interacted. One of my clients was a young female 18-year-old patient, 18-year-old client who had just gotten diagnosed with PCOS. Had no clue what it was. I didn't have any clue what it was. She didn't have any clue what it was, and I did one of my clinical cases on it. And really between her and I, we learned just kind of the significant health consequences associated with PCOS, as well as what this might mean for her for having a diagnosis that was really unclear. No one in her family had this diagnosis. She also had a family history of of bipolar. And so we were really working through this really complex experience of being diagnosed with something she didn't really have any familiarity with or understanding, or how this would affect, her future reproductive health, as well as trying to manage kind of a family with, bipolar symptoms. And that for me was really an example of, we need to do better to treat mental health in the context of chronic disease, and really pushed a lot of my interest in being a clinical health psychologist. So PCOS is characterized by clinical and or biochemical hyperandrogenism. So clinically, this looks like hirsutism, so facial hair around kind of the chin and the jawline. I have a patient right now with some pretty significant hirsutism, as well as acne. And then biochemically, excessive male hormone or an increase in androgen hormones. There's also polycystic ovarian morphology, so an excessive number of preantral follicles in the ovaries, or enlarged ovaries determined via ultrasound, as well as menstrual dysfunction. So amenorrhea, oligomenorrhea, and this can, if you think about each of these experiences alone, can cause significant distress in a person's life. And PCOS is, as a clinical health psychologist, I am so fascinated by it because it's reproductively, metabolically, and psychiatrically complex. As clinical health psychology, we really look at the intersection between disease and mental health, and this for me is like the pinnacle of it. And you can see it affects many areas of a woman's life, and a pretty significant proportion of it. So people who have PCOS features, compared to people who don't, they're more likely to be diagnosed with obesity, metabolic syndrome, have insulin resistance, or type 2 diabetes. They're more likely to experience infertility, pregnancy complications, or more likely to have miscarriages. They're also more likely to be diagnosed with anxiety, depression, and eating disorders. So you could see it can affect almost a whole person and how they feel about themselves. And despite this knowledge on the clinical features and medical comorbidities of PCOS, people who have it describe the diagnostic process as lengthy and frustrating. Some of them have reported that it can take up to 2 years to receive a diagnosis. And so if you think back on all of the signs and symptoms, that's a lot to be struggling with, facial hair around the jawline, wondering why, if you're exercising so much, you're still not losing as much weight as you think you should be. Part of this is potentially kind of this lengthy time in receiving a diagnosis. It's likely related to the kind of our provider's current diagnostic understanding of PCOS. It's been redefined 3 different times. Now we know to follow the NIH, the 2012 NIH diagnosis of PCOS, but certainly there's, depending on, I think, how you've been trained and where you are globally, then you might follow a different definition, or even just have time to look at maybe the polycystic ovarian morphology and realize if you don't have this, then certainly you don't have polycystic ovarian syndrome, which is not actually the case. Further complicating this picture is there are phenotypic differences by race and ethnicity in PCOS. So some studies have found that Southeast Asian women are more likely to present with dark discoloration on their face and bodies. In Middle Eastern and Latino women, they experience more severe hirsutism. And in Black women, they are more likely to present with higher BMI and metabolic features. So you could see, even though each of the different phenotypic differences are likely to fit within the 3 categories, they also tend to be treated individually. So if you're thinking about, let's say, seeing someone for hirsutism, that could be, being treated with oral contraceptives, or even, or you may not think you need treatment for, you may not think you need medical treatment for that. And so you go get laser hair surgery or do anything to make you appear or feel more as, I guess, feminine and more womanly, or what societal expectations of being a woman. And so I liken the PCOS assessment and treatment kind of to this figure. This has been one of my favorite figures to talk about when we're looking at maybe one aspect of disease. Doctors and scientists are often focusing on just one small piece of the problem and then determining various solutions in kind of from their own training and perspective. So one doctor might say, oh, look, this is just a spear. Another doctor identifies like, look, this is a fan. And another one will say, oh, it's a rope. But as we start to really, and really they're looking at an elephant, but one piece of the elephant. So as we emerge towards more multidisciplinary team-based science and clinical care, this would really leverage additional opportunities for us to view PCOS as a whole person problem and work towards early identification and treatment. So going back to the team health study. So this study, my study, is aimed to understand gaps in PCOS-related mental health care at the population health level. So if you, again, looking at the consequences of PCOS or the signs and symptoms, it's no surprise that women are more likely to be diagnosed with depression, anxiety, body image concerns, and eating disorders compared to women or people who don't have signs and symptoms of PCOS. So this study follows the Kilburn's framework for understanding health disparities in healthcare. Again, another one of the 100 frameworks that we have in implementation science. And specifically, the study is following the first phase, which involves detecting whether a health disparity exists and defining vulnerable populations. And so while the study is not specifically being done within a clinical care setting, future studies for team health will really work towards understanding multi-level determinants that contribute to health disparities with an eye towards reducing and utilizing various strategies such as developing interventions or changing policy to improve PCOS-related mental health care. So following the detecting phase of Kilburn's framework, the aims are to compare mental health and behavioral health outcomes among people with and without self-reported symptoms of PCOS. So we're looking at folks who don't have symptoms, self-report that they don't have symptoms, those who suspect that they have symptoms but have never been formally diagnosed, and those who have confirmed that they have had a diagnosis of PCOS. We're also examining the mental health outcomes and treatment satisfaction across the PCOS phenotypes. And I want to share that this study is also being done in both an English and a Spanish-speaking population. So we're trying to capture, as much as we can within this diagnosis. And then our third aim is to assess mental health providers' knowledge and assessment and management of PCOS, with the hopes to improve gaps in care, whether that is to increase access to care, increase mental health providers being able to determine or encourage women to receive a diagnosis. So we've facilitated, so using kind of, I wouldn't consider myself an epidemiologist, but we use, I guess, epidemiologic approaches to the study. So we facilitated a national online study to utilize multiple surveys to understand PCOS, its features and its consequences, as well as the medical history, mental health outcomes, as well as behavioral health outcomes. So you could see this is these are really long surveys. In hindsight, I'm recognizing that this is a large study. And then I had reached out to Dr. Mahalingai on her use of the ovulation and menstrual health history, which, in my opinion, has been one of the most comprehensive surveys that I've seen to capture PCOS in this treatment experience. So it's been really wonderful to be able to utilize that. So our target population enrollment in the study is 1,500 people. with a confirmed diagnosis of PCOS, suspected PCOS, and no PCOS. And we're using various online strategies to recruit this large number of participants. So you could see the majority of folks that we have recruited from is Research Match. And if you're not familiar with Research Match, it's a large kind of online, like national, I guess, platform to recruit for research recruitment. That's what I'm trying to say. It's affiliated with a lot of universities. So it's almost like a national online version of a college population sample. We also connected with the PCOS Awareness Association, as well as utilized, social media as well, and national and local networks for online distribution of our study. So currently we've recruited 714 participants. We're still recruiting for the study. And so while we're also wanting to understand race and ethnic differences in PCOS, we are trying to understand our best resource for recruiting a racially and ethnically diverse sample. So as you can see, most of our participants are still coming from Research Match. It's because that's the largest resource that we've used. That's the resource that has generated the most participants so far. But social media and the PCOS Awareness Association is also has been a pretty good use of our resources. So you could see, even though we only have 3 Native Hawaiian or other Pacific Islanders, most of them come from Instagram, not from Research Match. You could think about the types of populations and their demographics using Instagram as more of a recruitment strategy. And then more recently, we also used, we paid for promoted ad through Instagram to increase our enrollment of, people who identify as Latino, both English and Spanish speaking. This data is not reflected here, but, based on that, we just ended that last week, and that seemed to actually have been pretty successful in terms of our reach and recruitment of Latino women. Currently, the majority of our sample are white cisgender females with a mean age of about 32. They fall in the obese category and are fairly educated, and this is no surprise because our research, this demographic fits Research Match pretty well. So these are the folks who are more likely to sign up for Research Match and complete studies through there. So then we categorized our groups into, our no PCOS, self-diagnosed PCOS, and then our PCOS diagnosis. So this is confirmed diagnosis. And this is a lot of information to take kind of from the start. But if you're not a clinician or if you're unfamiliar kind of what these scores mean, just take a step back for a moment, because overall, everyone in this group is experiencing moderate to moderately severe symptoms of mental and behavioral health issues. For me as a clinician, I find that really concerning, because this group, everyone in this group requires clinical attention and needs further assessment and treatment. So even right off the bat, not even thinking about our PCOS groups on how we've characterized them, we're already missing, about 714 women who are potentially needing a mental health diagnosis. And then when we look at this from a closer perspective, unsurprisingly, our PCOS diagnosis group report to be the most impaired. And they are either the highest in our expected directions or lower in kind of the number of total minutes of physical activity that they receive per week. And then our self-diagnosed PCOS group, they're actually not pretty far behind from our PCOS group. There's a lot of concerning, when I saw this, I was like, oh, we have a problem. There are a lot of women and people out there who are meeting a mental health issue and need help. And it's even more concerning for me that the PCOS, self-diagnosed PCOS group are fairly similar to our PCOS diagnosis group. So we're missing a lot of gaps in many areas. And so given that we're still recruiting, we haven't conducted, any significance testing yet, but we anticipate that this trend is going to continue in this direction. So really, in short, this tells us we, as mental health providers and increasing access to care, we have a lot of work to do. We then looked at the mental health treatment experience, specifically within the PCOS group. So you can see most of them, about 66% of them, they have seen a mental health provider for PCOS concerns. 76 of them are currently seeing a mental health provider. So this is all good news. This is all bad news because they're not seeing a mental health provider and have never seen one. Sorry, I flipped that. But when they do see one, 72% report being satisfied with their current treatment. So it's less about whether they are satisfied with their treatment and more about increasing the access to care here, because we're missing a significant proportion of folks who could definitely benefit from mental health support. I mean, in my opinion, I think everyone could benefit from mental health support, but this group in particular, they're a pretty high risk for some long-term health concerns and issues. So I just shared just a small snippet of our current results because we're still on ongoing data collection and recruitment, and we're also still, the ovulation and menstrual health survey, that's a big survey. And so I think we're also still kind of sorting through how we understand that data a little bit. But so I just shared just kind of a small snippet of where we are with our current results. And we have so much more to analyze, but really the strengths of using kind of an epidemiologic approach to start in this study is it's a large data set to help us understand a population, an understudied population, to help build a research registry. We asked participants if they wanted to be contacted for future studies. And I think we have had a fair number who've said yes. So that helps us build a national research registry to continue to improve women's healthcare. It was also a relatively quick approach to determine the gaps in care. So even though we utilize a number of studies, it's one quick way to gather data pretty rapidly. And then by following the Kilbourn's framework, we were able to define a vulnerable population and measure a health disparity issue. But the challenge of this kind of recruitment are that, we still need varied recruitment strategies for diverse populations, both at online population health level, as well as through the local level. So this would mean kind of recruiting people on the ground through community partnerships, through in-person and community and online community partnerships. Another challenge is that this is really just more of a one-time assessment of symptoms and functioning. And so we're not looking at this from a longitudinal perspective, although we can. We also didn't include, now in hindsight, I'm thinking we didn't include questions to control for the effects of COVID-19. As we all know or have experienced ourselves, the last 2 years have really, the mental health need is just so high. I'm seeing it in my own clinic, talking within my own networks, it's really high right now. The Red Cap build also took about 4 months to put together, so it was pretty lengthy, or it took some time. And then the surveys we utilized are typically lengthy, and they're not patient-centered, meaning we wouldn't really use them in actual clinical care settings. So because of the length of time that it took, it's likely that we lost a significant number of people who are eligible and have not fully completed all of the surveys. And so we're still missing folks in that category as well. So some key takeaways, and I know I'm kind of coming up to the last 2 minutes. I'm going to go through the last 2 slides pretty quickly. So utilizing epidemiologic methods was really fruitful to determine kind of PCOS risk trends and trajectory. We'll be able to hone in again on the scope of the problem, as well as inform intervention approaches and needs, and contribute to systems thinking of disease incidence and prevalence, while implementation science methods could be utilized to develop and rigorously evaluate the interventions to reduce disease incidence, evaluate problems at multiple levels, and determine effective dissemination strategies to expand the reach and access to care. Again, all in the aim of improving population health. And so for future directions for the team health study, we're planning to develop, that's actually in process, developing a multidisciplinary clinic and improve training for mental health providers in PCOS care. We're having our next meeting tomorrow, actually, on how do we, with psychiatry, OB-GYN, endocrinology, nutrition, dietitian, on how do we build this multidisciplinary clinic, dermatology. And there are just a few multidisciplinary clinics across the country specifically for adult women. We can also utilize this data to plan for a large-scale multi-site study to assess the reach and implementation of mental health treatments, and really study, how do we get this out there? And given that, many still remain highly underdiagnosed, we need to look at effective strategies to reach patients with even mild or just a few symptoms. We'll also plan to engage stakeholders to create patient-centered messaging to increase awareness of PCOS. And finally, I'd love to partner with digital mental health therapeutics for national intervention rollout and evaluation. This would really help us towards reducing the burden of the syndrome for everyone and getting the word out there for those who really need it most. So thank you so much. I'm surprised I went the full 40 minutes, and I am happy to take any questions.
Thank you so much. Zoom applause. That was so interesting and definitely broadened our view of how to incorporate an implementation science frame of research as well as dissemination science. I just will start with a few questions since the chat is not active yet. Of course, it is a pleasure to share the Health study survey with you, having been a Birch Scholar and taken, a couple of years to field test that. I'm glad it's in
Wonderful
use. Can you share how much of the 714 individuals were Spanish speaking only?
Oh,
it's okay if you don't know it off the top. It's something I'm curious about.
I'm really happy with my statistician Rachel is on.
Okay.
She could probably actually pull that information quickly. It's not as much as we had thought, and we looked at kind of, so when you build the red cap, we had to do it in English and then had to do it in Spanish, because we had to change the entire interface to Spanish. And I think it's I want to say it's over close to 100.
Oh, she just pulled it. It's in the chat. 31.
Oh, 31. Never mind. Yeah. So so that's, thanks, Rachel. You're on. Yeah. So yeah, but the thing about research match in particular, and this is, I think, a limitation of research match. So, and Perla, who is my research assistant, I'm so glad my team is on. This is great. Because then I can just ask no questions. Perla has been really working hard to recruit a lot of our participants through Research Match. And it's been, so what we'll do is what she will do is if they identify as Spanish speaking, she'll put kind of our flyer in Spanish language at the top, but also put the English one. So it's very likely that even though they indicate that they're bilingual, they might feel more comfortable completing the English version of the red cap. So we could be capturing maybe more Spanish speaking folks or folks who are bilingual and might be more comfortable. So this is where we utilized Instagram in particular to help us recruit more, Spanish speaking only Latino women. And I think we've gotten like two from there. We had like 700 folks who've started our study specifically just through Instagram. Maybe have had about 130 or so who have completed it. Latino women have completed it. And I think 2 are Spanish speaking. So we're trying, but
yeah, no, it's so
tricky.
interesting. I didn't use the Spanish home health survey yet, so I'm curious to know.
Yeah.
Did you find Research Match? I was just curious, how many people in Research Match as like a total population? And it sounds like you also are recruiting people with different like language fluencies from Research Match also.
Research Match is it's a very large, I'm not an expert in Research Match, but it's a very large population, but it does tend to be more, because they're affiliated with universities, it does tend to be more of a highly educated population. I in kind of one of the earlier versions of this talk, I included kind of a map of where most of our responses had come from. And many of them have come from Ohio. And I was like, what is going on in Ohio that are getting people so jazzed about the study? And we looked at the Research Match map of affiliated universities, and the majority of them are in Ohio. So yeah, I was like, oh, that makes a lot of sense. And so a lot of our responses came from Ohio, Texas, California, and New York. So now we're actually starting to, the nice thing about Research Match and really kind of doing interim checks of where we're recruiting is we're starting to be more targeted with our recruitment. So before we were being really broad. And again, this is the reason this study is called Team Health, and it's intentional because we didn't want just folks with PCOS. We wanted people who had symptoms of PCOS, but didn't know that they had symptoms of PCOS. So our criteria are really broad intentionally, so we can capture as many folks as possible. And then from a data analysis perspective, we categorize them ourselves. And so now moving forward, we're starting to be more targeted with our recruitment strategies of trying to increase, racial and ethnic diversity, and using Research Match and just targeting those folks, as well as, we might consider utilizing Instagram again. I think it was like $500 to, we got a fair number of people we had a really high percentage of what they call as click-through rates. So our percent was like about 2% of people who actually looked at the ad and clicked to our study, whereas what's out in the industry and in market, it was like 0.7%. So we actually had pretty good recruitment rate through Instagram. And I'm happy if that's something that you and your team are exploring. I'm happy to connect you to our communications team. They found that $500 is about kind of the sweet spot for recruiting, and I was like, oh, that's not too bad. $500. So
interesting. Yeah, that would be great. I wanted to open it up to our listeners and any other questions. I will follow up with you on email and a couple other thoughts. Please. So you have some, maybe can link to a couple others. There's one researcher who is an REI in UCSF, Heather Huddleston, and she does approach to kind of a multidisciplinary care for women with PCOS. So there's often a psychiatrist or a social worker in her treatment team. So I'll look forward to connecting you to that. But
that would be great. I know UCSF have another large multidisciplinary PCOS clinic. The two I know are UCSF and Anuja Dokra's team at Penn.
Yeah. So Heather's team is the one that runs the UCSF unit. So she has her baseline mental health survey is comparable, in a clinical environment. There's other challenges. So I don't think it's potentially as comprehensive, but it's a very unique look at bringing in kind of a lot of surveys into a clinical context to facilitate diagnosis and management. A little different, you're in the clinical setting, but using kind of these tools. So it could help. And it's exciting to see this kind of work. I think so much is needed here in the mental health and PCOS space. So
yes.
I'm excited to hear more as your study develops. And I'll turn it over to Ariel to conclude.
Oh, are there any other questions? I have a question, but it's a little more lighthearted. So I want to invite any other questions prior to mine. Okay, so I love implementation science, and so I am so thankful for this lecture today. It is absolutely, from the last study that I'm coming from, one of my largest passions. I would love to know what your favorite framework is out of the hundreds that exist.
So that's a good question. It's not a lighthearted question. It's a good question because I think everyone has a favorite framework. I think I have to, I'll go back to the framework slide, but because I did my training here in implementation science, and Russ Glasgow, who developed the RE-AIM framework, he's here, he's the director, he was one of my mentors in the implementation science program. I think I'm supposed to say the RE-AIM framework, although I do like it. I actually do like it because but I have found that using I want to say the EPIS, and it's called exploration, preparation, sustainment, or implementation and sustainment. That's another framework. It's super comprehensive framework where we're looking at both the contextual factors that influence implementation as well as what can help sustain it. But I do like REACH a lot because it's simple, it's straightforward, and REACH is combined with PRISM. I know I'm throwing a lot of acronyms out there. Implementation science also really loves acronyms. PRISM looks at the contextual factors to actual implementation. So, but there are quite a lot, and I also have really liked using Kilbourne's framework, the one that the team health study is on, because I think and implementation science is, and I think a lot of scientific fields are pushing for this, of really explicitly trying to understand health equity and having a health equity perspective in mind. And I have liked Kilbourne's, and I've used it for many different studies because, one, it provides just a nice framework. You could look at health equity at many different phases, and then how do we improve health equity across the board. So I've liked utilizing Kilbourne's a lot too.
So I know we're at time, but that was actually one of my other questions for you was, is the Kilbourne developed out of the TTM at all? Because it seems to have a lot of the similar, shorter, not all 7, but shorter, similar with pre-contemplation to contemplation, just on a population level.
Yeah, I was thinking I was wondering trans theoretical model. Is that?
Yeah.
Yeah. I don't know. I don't think it is, but as you become more involved in implementations, they're all very similar. So there's a lot of overlap. I imagine that it did come from TTM or TTM, and to help inform that. But implementation science really looks at the multiple level perspective, and I have liked Kilbourne's because it's been, from a health context, it's been one way for us to really look at it.
Well, thank you so much for your time today. This has been
absolutely.
an absolutely wonderful lecture. We will definitely be in touch, and I hope you have a wonderful day.
All right. Thank you. Thank you, everyone. Appreciate everyone tuning in.